Mr. Jones, you have the floor.
Okay. Good afternoon, everyone. My name is Jim Jones. I'm the Executive Director for GuidingPoint. And today I wanted to present on substance use and mental health treatment in the community because I know that that's something that's very important. I feel like a lot of individuals in the community, even though there's a lot of services and a lot of service providers, we're still not reaching everyone. So and sometimes that's because of transportation issues. Sometimes it's because of, a lot of different things, barriers that stop them from getting treatment. So today I'm just going to go over a little bit about substance use treatment and mental health, and then I'm going to let Mrs. Rees talk about a little bit about our new programming, IOP programming a little bit, and then we're going to circle back for questions and answers. All right, go to the next slide. Okay, so I just kind of wrote mental health and substance use disorders affect many people, including friend, neighbor, and relatives. Per report from SAMHSA, these illnesses are common, reoccurring, and often serious. And what I want to say is the reason I kind of put that in there is because I had opened our harm reduction clinic in Lorraine County. And a lot of people, judges, lawyers, you would be surprised, had a lot of misconceptions about what mental health, who had these mental health disorders. And when I looked at people and I said, it's your cousin, it's your uncle, it's your brother, they kind of stood back and said, yeah, he's kind of right. So sometimes there's a lot of misconceptions about these issues. So it goes on to say mental health disorders involve changes in thinking, mood, or behavior. These disorders can affect how we relate to others and make choices. I think we all know that. Um, and reaching a level that can be formally diagnosed often depends on a reduction in a person's ability to function. So we know that it's not always just because someone uses maybe alcohol sometimes on holidays or something, we know they don't have an issue. Uh, so I kind of lined it up so it's mental health versus substance use disorder. Serious mental illness is defined by someone over 18 having within the past year a diagnosable mental behavior or emotional disorder that causes serious functioning impairment. Now, I said 18, but truly, we know a lot of kids are diagnosed with these mental illnesses as well. So I'm just using the adults for this purpose. Substance use disorders occur when the recurrent use of alcohol and or drug causes clinical significant impairment, including health problems, disability, and failure to meet major responsibilities at work, school, or home. And what I'll say is, so for severe mental health illness, you can have that without having substance use disorder, right? But you can't have substance use disorder without having mental health illness because that is a DSM diagnosis. So dual diagnosis co-occurring disorders refer to having coexisting mental illness and substance use disorder, while commonly used to refer to the combination of substance use and mental disorders. The term can also refer to other combinations of disorders. So sometimes you'll hear people using this language, and I wanted to touch on that because they'll say dual diagnosis, but sometimes that could be something like dementia and schizophrenia, or it could be something like some kind of health condition, serious health condition, and a mental health issue or a drug substance use issue as well. Sometimes they have all three. So I go a little more into co-occurring disorders. People with a SUD disorder, so substance use disorder is what the acronym stands for, may also have other mental health disorders, and people with mental health disorders may also struggle with substance use. These other mental health disorders can include anxiety, depression, attention deficit hyperactivity disorder, bipolar disorder, personality disorders, and schizophrenia. But I would say what's common is depression and anxiety is very, very common. Um, so, and then I got the information from NIDA. So it's from the common comorbidities with substance use disorder research report. Sorry. All right. Mental health symptoms commonly associated with SUD: depression, also known as major depression, major depressive disorder, or clinical depression, is a common but serious mood disorder. It causes severe symptoms that affect how a person feels, thinks, handles daily activities such as sleeping, eating, or working. To be diagnosed with depression, the symptoms must be present for at least 2 weeks. And I think that's a lot with a lot of different symptoms, symptomology. And then I go into general anxiety disorder. Like I said, I just picked the disorders that are common amongst the population. So generalized anxiety disorder usually involves a persistent feeling of anxiety or dread, which can interfere with daily life. It's not the same occasionally worrying about things or experiencing anxiety due to stressful life events. People living with anxiety disorder experience frequent anxiety for months, if not years. So we all have anxiety, but we don't all have clinical anxiety. Then I go into a little bit about bipolar disorder. And there used to be a disorder called manic depressive disorder, and then it turned to I think it's bipolar 2 now, um, and is a mental illness that causes unusual shifts in levels and concentration. These shifts can make it difficulty to carry out day-to-day tasks. There are three types of bipolar. All three types involve clear changes in mood, energy, and activity levels. You'll hear bipolar 1, bipolar 2. You'll hear people use those terms. These moods range from periods of extreme up, elated, irritable, or energized behavior known as manic episodes to very down, sad, indifferent, or hopeless periods. So, and I gave you guys these definitions because I didn't know everyone's understanding of the different mental health disorders or substance use disorders. So I wanted to make sure I kind of went over that before I kind of went over some of the programming we're offering. And then it talks about schizophrenia as a serious mental illness that affects how a person thinks, feels, and behaves. People with schizophrenia may seem like they have lost touch with reality. A lot of times, people with schizophrenia have a lot of symptoms that people with dementia have as well. So you'll see there's some differences, but there's some commonalities too. The symptoms of schizophrenia can make it difficult to participate in usual everyday activities, but effective treatments are available. Many people who receive treatment can engage in schoolwork and achieve independence. So I just kind of gave you the diagnosis, and then talk about, when someone has an SUD and another mental health disorder, it is usually better to treat them at the same time rather than separately. Sometimes people would say, no, I'm going to treat the mental health disorder before the SUD disorder. It just goes, here at GuidingPoint, we treat both disorders together. And we do like a dual diagnosis treatment um, for residents in Cleveland. So important fact continued. It also is essential that the provider tailor treatment, which may include behavioral therapies and medications to an individual's specific combination of disorders and symptoms. So that's kind of common practice. Sometimes it's a combination of medication, mental health treatment together, and treating both diagnoses at the same time. So here we're going to go into treatment options a little bit. So one of the types of therapies we use at Guiding Point, and I'm going to back up just for a minute because it's not on the PowerPoint, I don't think, but we're now providing dual diagnosis treatment and IOP treatment, intensive outpatient treatment, for a lot of residents in the community, where we're providing, the IOP is 3 times a week, 9 hours a week, in a group setting, and then we do individual work as well. So, and this is and with IOP, we use a matrix model, which has cognitive behavioral therapy, motivational interviewing kind of mixed in. It's a very specific model. But this is CBT. Um, So CBT is all about how you process things cognitively and behaviorally. So you'll see people use things like the cognitive behavioral triangle, feelings, thoughts, emotions is a very basic, but there's also a lot of mindfulness too that goes in there. DBT, dialectical behavioral therapy, where we use concepts of mindfulness and acceptance or being aware of the attentive attentive to the current situation and emotional state. DBT also teaches skills that can help control intense emotions. So you'll hear that DBT really uses the five senses to really go into stabilizing your mood. And it talks about, the three different types of minds, and things of that nature. That was a type of therapy that was invented by Marsha Linehan. Um, and CBT was Aaron Beck. If anyone's interested in that, talk about it later. But ACT ACT is a assertive community treatment. It's a form of community-based mental health care that emphasizes outreach to community and an individual treatment approach. So there's two types of ACT, right? There's an acceptance commitment therapy, which is a type of therapy, but there's also a thing called an ACT team that treats people with schizophrenia, and they use a CBTP type of therapy to treat people with schizophrenia. So I just wanted to, let people know that that type of treatment is out there. And there's several programs and there's several agencies that have an ACT team. So like, I don't know, Guidestone, I know they have one. I know that Belfair has one as well. So um, therapeutic communities are a common form of long-term residential treatment that focuses on help people develop new and healthier values, attitudes, and behaviors. So um, a lot of this is like your in your residential, we had adult behavioral health where people who couldn't function on their own, they're living in things called permanent supportive housing projects they would live in, which is like CMHA sometimes, but with more intense treatment around them. Sometimes residential as far as group homes, which isn't like a CMHA is like independent, right? An apartment, but like residential where you're in a group home, and I keep admitting people. So where you're providing case management, therapy, and things of that nature to make sure that people are functioning. But a lot of times in public housing, there's a lot of services available to people in there, and that's why I mentioned CMHA housing. Contingency management principles encouraging behaviors by offering vouchers, rewards, and desired behaviors. So a lot of times people will use this technique to help challenge negative thought patterns and improve positive behaviors. So, and then we kind of go into the aftercare, and I kind of ran through this really quick. Um, so at Guiding Point, so we're going to be providing, and we have had a partnership with CMHA where we provided services for the residents there. But more recently, we are starting a service there where we're having someone based in we want to have someone based in one of those facilities, in several of those facilities, and it's a volunteer basis where someone will come and they will, if they want the treatment for mental health and drug and alcohol use, it's all voluntary, but there'll be someone on campus that'll be able to do that. That way, things like transportation and other barriers won't get in the way. Ms. Reeves, do you want to talk a little bit more about that? Ms. Reeves? Okay. Well, I thought she was on, so she's not, but so we'll be providing, so help providing some substance use treatment on campus there, and that way transportation won't be an issue. Also, we'll be able to do some case management services to help out with some of the transportation issues that residents are having. It's all going to be voluntary, just like any mental health service. So it's only for those residents that really would like to receive services. And like I said, we've worked with the residents in the past. The main difference would be there'll be someone in the building that they can come and communicate with. Oh, there you are, Miss Reeves.
I was trying to unmute.
Okay. Did you want to talk a little bit more about that, Miss Reeves?
Well, we just going to say, I just want to kind of plug in on what you're saying, that not only will we continue to help after the assessments and all the planning and the individual treatment plans, we also will be making sure that that case management and that therapy is right alongside, walk alongside of the treatment programs. But we will also have an opportunity to work closer with the housing units and other wraparound resources that that person may need. So anything after that care plan is in place, we will know better how to help assist those persons. And we look forward, because they are the king, and I say the queen, of their own recovery process and their own care plan. So we are looking forward to being a part of that process. And again, we will be working on site, and maybe at this time we're also looking for some things that's off site, but mostly on site. Easy accessible transportation will be also to a minimum, but available in some situations to make sure of the success of that person's able to attend the programs.
Awesome. Thank you, Mrs. Reeves. And so it's important to note that we'll be providing, the mental health and drug and alcohol services. So what we'll do is we'll do an assessment on site, and then we'll do treatment plans, and we'll provide therapeutic services and case management services there. We'll also run groups there as well for the residents, doing dual diagnosis treatment, utilizing the matrix model. And then when we've done that, we'll also do some individual work with the client as well. So some people do not do well in groups. So we'll provide individual, and we'll also provide individual work for people who don't want to attend the groups. But even after they're attending the groups, if they want, more intense treatment, we could do more individualized treatment. And then here I'm talking about an aftercare plan, which includes activities, interventions, and resources to help recover persons coping with triggers, stress, and cravings that they may face when treatment is over. So we want to definitely make sure that we're doing we have a good plan. Of course, we start discharge planning the minute we intake people, because, they have to have goals set to be able to meet to eventually be discharged. The goal is to get them stabilize and to a place where they feel like they can manage their own mental health and behavioral health and substance use issues. But we also link them with things like AA groups and other aftercare programs as well. Right now, we're not, and so one of the questions in the box was, are these services available for voucher holders? Right now, we're not part of the voucher program. So I'm gonna let Ms. Reeves, do you know a little bit more about that? She's probably trying to hit on mute again.
Yes, right now we are trying to we are making sure we're going through the right application process, because the voucher program isn't assigned for a certain specific type of application process. And so
Okay,
we are in the process of that at this moment, but it has not been certified with us as of yet. But anyone with Medicaid and some of the Medicare programs, but definitely a lot of the state health insurances qualifies. So
okay,
sometimes people have a voucher, but they also have the state insurances. And sometimes that's an overlap and that qualifies them a lot of time.
okay, okay. There was another question as well as what properties will be at. I don't have them written down in front of me right now, but I know we're going to start in 4 different properties. So I can't remember right now what 4 properties. So I apologize for that, but I can get that information for you later. And then another question was, if the resident has mental health services with another agency, can they work with GuidingPoint for substance abuse, or should they work with GuidingPoint for dual services? And I think, yeah, so that's kind of what I was talking about with if you have substance use and mental health, you need to treat both. Um, so the thing is duplication of services. So if you're billing Medicaid for therapy, whether it be substance abuse focused or mental health focused, 2 agencies can't bill for therapy at the same time. It is a duplication of service. Even though the services appear to be different, they're still treating mental health diagnosis. So I think that like one could treat case management, do case management, and the other can do therapy, but they both couldn't do therapy at the same time. So in that case, we would work with the organization that's already working with them, and part of the discharge planning. So let's say they say, well, we're going to go to Guiding Point for dual diagnosis treatment. Part of the discharge planning would probably be to discharge them back to their primary agency that they were with before once treatment services uh, were finished. Now, the IOP service only lasts 3 to 6 months. So it's not for the IOP, it's not going to be something that's going to last for a longer period of time than that. Usually, that's when we end service, and then we would look at discharging back to their primary organization. Hopefully, that answers your question.
Mr. Jones, I want to jump in right there for just a moment. I know there was something about what building. Right now, we are waiting for management to finish doing their assessment of the need concerning what building would be selected at this time. They have suggested certain buildings within the organization, but they will give us clarity in the near future concerning what building we will be staffed at first.
Very
That's
good.
by the CMHA management team.
Very good, Ms. Reeves. All right. Um, Ways to meet aftercare needs. So, uh, we continue the treatment options. We could, like I said, we could step them down to a lower level of care, um, get them involved in a 12-step program, AA program, monthly outpatient visits. Maybe they just see their therapist that they're seeing at Guiding Point a lot less. Maybe they see them monthly because they have a good rapport and they want to continue the relationship with their therapist there. Recovery support groups. We're going to be running that too. Communicate. And I'm also looking at getting some peer support as well for the individuals so that they have that constant support. Continued strategies, utilize their hobbies, so we're utilizing the strength-based approach really, um, and trying to teach them to surround themselves with more positive influences and things like that. Good afternoon, my name is, I wanted to know what this meeting is located. I don't understand the question. Matthew, can you clarify your question? This is Matt. Okay. Well, I'm gonna keep going, but if you can clarify and put it in the comments, that would be great. And how to help. Beginning after plan care plan and at the beginning of services. So I talk about that. Discharge planning is crucial. So we do the discharge planning right at the beginning because we want to know where we're going to go. Where are we going to get to? You know, we don't want people in treatment forever, you know, so eventually they need to get a lower level of care and move to the next level. Um, so, um, so so we'll set the goals. Client will look with will work, it's supposed to say work with clinician into other service providers for mental health after discharge. So we're going to coordinate with other service providers. We're not just going to monopolize services for sure. Client will take, you know, they need to take all their prescribed medication. They will be able to meet with TX team monthly or bi-monthly instead of weekly when stepped down. We talked about that. Um, so it's kind of like the discharge planning, like what we're looking at the end. And so that's the end of my presentation for this. Are there any other questions? And now you can speak freely, I think, and ask.
They sure can. Thank you, Mr. Jones. Anyone else have any questions? You can unmute yourselves to ask your question, or you can pose it in the chat. Okay, so we have a question from Ms. Lassiter. It says, does GuidingPoint help clients who have been previously misdiagnosed from possibly another provider with better mental health treatment? How are you able to assist, support, and correct their care?
So when a individual comes into GuidingPoint, immediately we do our own assessments. So we'll be doing an assessment that encompasses mental health and substance use treatment. So we'll be working towards that. I can't speak for other organizations and what they've misdiagnosed. What I can say is that um, they will be given the proper diagnosis through our assessment process. And we really, even if you have a previous diagnosis and assessment, we really would have to redo the assessment anyways, because we'd want to make sure that we caught everything. I'm a strong believer that believes in continuity of care, meaning that one of the ways you build a rapport with a client is really doing that assessment and really getting to know them in detail and what's going on in their life. And the way to do that is through the assessment and through the treatment planning process. Hopefully that answers the question. Any other questions?
Okay, so it says here, may the presenter please put their contact information in the chat.
I also have it on the screen if you see right there where it says thank you, but I will put it and I prefer to go by Jim, just so everyone knows. Jim Jones. But let's see, 440. And then oh, it keeps going. And then
So for all of you that have chosen to call in and you can't see the screen or the chat, the number is 440-506-1568. Again, that number is 440-506-1568. 1568.
Welcome. So the first question was, why is there such a stigma on mental health? I think a lot of times people blame mental health issues for bad behavior, right? You see that on news a lot. You see a lot of people doing that. And I think it's just a lack of education on diagnosis, lack of education on, you know, what type of people have mental health issues, because I think society tends to eh, say, well, someone has a mental health issue because of X, Y, and Z, instead of looking at, 99% of the population has been traumatized in some form or fashion. So I think, and as we become more aware of mental illness, we're becoming more aware of how many people have mental illness in the United States. So I think the stigma is becoming less and less but we just need to continue educating the community, and I think that's really going to help us get rid of some of the negative stigma for sure. Also, what is the referring process? So we have a referral form. I'll have Mrs. Reeves send those out. We have referral forms for our treatment, and we will have them at the locations that we're going to be at as well. But we can email you the form, and we also have our person is Jessica. I can't. Mrs. Reeves, can you
Yes, we
talk a
will
little bit
have,
about the referral
yeah,
process?
so the
Yes.
referral forms we'll go through, we will definitely send them to Mrs. Santiago. And that way she will have an opportunity to share them with her staff, and then they will get them back to us. And so on that referral form, it will have the contact person, and you can personally send them back in, photocopy them back in. There will be a number to a young lady, Jessica Simpson, on the bottom, or Sarah Thomas. But there will be a referral number where she can tell you what else you may need during that process of time. But it's a very simple referral form. It's not difficult at all. You would just have to make sure that the insurance information is current and up to date. But we will definitely make sure Ms. Santiago and her team have that information before end of day. Thank you.
So thank you,
Thank
Mrs.
you.
Reeves. And also, it says, how do I get someone to go? I think one of the most important things is, not, we don't want to push someone into treatment. What I always do is, I communicate with them, and say, hey, this service is offered. This is where it's offered through. No pressure. They're not watchdogs. They're not going to report anything, because some people are on probation and things like that. When they get into treatment, they're worried, someone's going to find out about the treatment and stuff. So it's all confidentiality, all confidential. I think that's important. But I don't want people to feel pushed either. I want people to come because they really truly want treatment. So hopefully that answers your question. Any other questions? Welcome. All right, I think that's it. So
Mhm. I don't see any more questions in the chat either. So thank you to our wonderful presenters. We really appreciate it. Will this presentation be made available via email?
sure.
Okay,
Yep, we can make it available.
wonderful, wonderful. So everyone, I hope that you enjoy the rest of your Tuesday afternoon. Is there another comment? I just saw something. Oh, just someone else saying thank you. Again, thank you to our presenters. Thank you to everyone that decided to join today's webinar. Our next webinar will be actually in person. Well, our next Family Self Sufficiency gathering will be in person. Again, we will be hosting our job fair at Lakeview Community Center on May 14th from 2 to 4 p.m. The Fifth Third bus, the e-bus, will be there as well. So we are trying to spread the word. If you know someone that's interested, please let them know. I'm going to check the chat one more time. Ms. Lassiter says group sessions. I guess she has a question about group sessions.
What?
So Ms. Lassiter, can you elaborate? Are they
Yes,
offered?
yes. So that's part of the IOP, intensive outpatient. It's that's where I was saying that they're offered 3 times a week, three hours a day. So the group runs 3 hours for a total of 9 hours a week in the week.
Thank you. All right, everyone. So this has been a fantastic webinar. I'm going to go ahead and end the meeting. Once again, the information will be shared via email. So thank you, thank you, thank you. And I look forward to seeing everybody at the job fair. Take care.